Hi, Tom Davis here. I want to welcome everybody to this week's happy hour session. We're very pleased, and I'm very pleased to introduce one of my colleagues, Dr. Trey Martin. Trey has had years of experience reading dermatopathology. He's also boarded in anatomic pathology and clinical pathology and has served as the laboratory director at a number of very large laboratories. He has a wealth of experience, and I couldn't think of anybody better to address the issues of some principles regarding special stains, histochemical stains, and immunohistochemical stains and their application to diagnostic dermatopathology. If you have any questions at all, you can submit them to education@sagisdx.com. I've got the email up in the chat. Likewise, you can also email me personally, tdavis@sagisdx.com. Certainly for those of you watching the recording of this session, I would encourage you to do that. So without any further hesitation, I would like to introduce and turn the floor over to Dr. Trey Martin. Trey?
Hi, Trey Martin. I'm one of the partners and the laboratory director at Sagis. I'd like to thank Dr. Davis and the education team at Sagis for asking me to do a quick presentation for you this evening. He asked me to do it on special stains and immunostains, and I want to really focus on applications and some getting your eye used to what they look like, and then some examples that'll give you at least 2 or 3 board questions, so that you can check that off. And I know that's the ultimate goal of a lot of this. So let's begin. Let's not waste any time. Let me start the screen share presentation. So basically, special stains, their uses in board Perls. That's the crux of it. So we got to start at the beginning, right? Begin at the beginning. And our standard stain that we use is the hematoxylin eosin, which you're all familiar with. But that only gives us so much information out of tissue. So we use special stains to glean a little more information or highlight certain things. And we can highlight connective tissue, including basement membrane, collagen, elastin, and muscle for different disorders. Deposits, we can detect amyloid, mucin, calcium, iron, copper, melanin, organisms, different bacteria, mycobacteria, fungal, parasites, spirochetes. We can look at nerves. We can look at fats with different special stains. And then we can look at targeted cells, for instance, mast cells, myeloid cells, melanocytes. We have different stains, either conventional stains or immunostains to help us. So let's start with connective tissue. So in one of the big ones, the 2 big ones I'd like to talk about are Masson's Trichrome, which you might see, but and then Verhoff and Giesen looking for elastin fibers. So a Masson's Trichrome stains nuclei black, cytoplasm, muscle and RBCs red, and collagen blue. So here's an example of this: muscle red. See, here's the muscle. Connective tissue blue, keratinocytes actually stain red here. And here's a Masson and an H&E of skin right side by side. And you can see that the connective tissue is staining blue, etc. So just want to get your eye used to that. Here's a trichrome stain, which stains collagen and nerve blue, muscle, elastin fibers, RBC, and cytoplasm red, and nuclei purple. So this is a blood vessel. Here are the RBCs in the center here. The connective tissue here is staining blue. The elastin fibers is bright red. So that's the elastin layer of an artery. So we could actually detect an artery using this. And here's muscle, the muscle layer, which is staining red. Elastin tissue, this is a good one to learn. This will be on your boards almost certainly. So we need, whenever we want to see disorders of or elastic tissue increased deposition or absence, we look for elastin tissue. And one of the big ones we use is the Verhoff van Giesen, which stains elastin tissue black. And here's an example of this. So here is skin. Here you can see that the elastin fibers are staining black. Do you see that here? Here it is close up, black. But there's big holes here where there's no elastin tissue. So that tells us that's a disorder of elastin tissue, be that a scar can cause this, or mid-dermal elastolysis, or different things. But different characters of the elastin fibers can give you different staining patterns. Reticulin stain, just wanted to mention it real quick. This reticulin fibers are a type 3 collagen and basement membrane, type 4 collagen and laminin, and it stains it black. And so like here's a liver, and you can see the reticulin network here. Here it is right there too. And here's kidney, the basement membrane, you can see is staining black. We can look for mucopolysaccharides in the skin, PAS. We can use a periodic acid-Schiff stain. We hear PAS all the time, but it's periodic acid-Schiff. We can use colloidal iron, toluidine blue or Alcian blue. In the PAS reaction, basically we oxidize carbohydrates to aldehyde. And then so that's the periodic acid portion, and the Schiff reaction stains aldehyde groups red. So after we've oxidized the carbohydrates to aldehyde, we stain the aldehyde red. And it can also stain basement membrane, glycogen containing cells, fungi, neutral mucopolysaccharides, and we can do it with or without diastase. So you'll hear that. And diastase simply splits, digests glycogen. It's the same enzyme that's in your saliva. So we can detect diastase by digesting it. So here's an example of a PAS stain where it's staining the basement membrane red, blood vessel walls are stained red, and here's the glycogen and some keratinocytes. So if we were to add diastase to this, that glycogen and the keratinocytes would disappear. We'll see an example of that in a second. But you can also use PAS for glandular mucin. So here is cells producing glandular mucin within the epidermis, and so this would be an example of an extramammary Paget's disease. And here, and here you can see it staining glandular mucin of like a stomach or colon. And here's the example of PAS with diastase and without it. So here it is without diastase. On the right, you can see the glycogen and the keratinocytes like we saw earlier. And if you add the diastase, it's gone. And so what this does is it kind of cleans up the stain and removes anything that's glycogen. And so you could see fungus better here, or you could use it actually as a test. You could run it side by side and say, that red was actually glycogen. And here's some fungal element staining when to get your eyes used to this. So here is the epidermis, here's the cornified layer, and sandwiched in between two layers in the cornified layer are hyphal elements. So this is a dermatophytosis. And we call this the sandwich sign here because you often get either a splitting or a difference in the character of the cornified layer. It's often compact orthokeratosis below the fungus and either a less dense or a second layer above it. And sometimes you'll even have the basket weave orthokeratosis of normal cornified layer here. We call that the sandwich sign. Colloidal iron, this is going to stain for mucins, and we can use a Perls modification for iron. Okay, so I just wanted to get you used to this. So there's Hales colloidal iron for mucin, and then there's Perls iron stain, which is the Perls modification that's going to give us iron. Okay, so here's colloidal iron and Granuloma annulare. In Granuloma annulare, the center of the palisading the center of the palisading granulomas contains mucin. So it's not showing up well here, but there's a palisading granulomas process right here. And when we put on our colloidal iron, we see that we can see big chunks of mucin in there, confirming the diagnosis. Another thing that you'll see, another entity that you'll see mucin deposition is in scleroedema. Okay, so in scleroedema, you're going to have haphazard collagen bundles, and they're kind of separated by spaces on H&E. And then when you throw on your colloidal iron, voila, those spaces contain mucin. See it? Confirming your diagnosis. And here's the Perls modification, which actually stains iron. So you're going to see iron deposition with this. It's going to stain blue. And you can see this in a bruise, or certain tumors often have lots of hemorrhage, and which leads to hemosiderin deposition, and you can detect it with the Perls iron stain. Alcian blue, we also use this for mucin, and it can stain epithelial mucin, blue here. Here you can see it in some GI glands, and it actually stains cartilage blue too, if you needed to look at that. So let's move on to some other deposits like melanin, calcium, and amyloid. So for melanin, we can use the Fontana-Masson stain. For calcium, we can use von Casa or alizarin red. Alizarin red. I'm not sure how you pronounce that, to be quite frank. No one uses it anymore. Everyone uses von Casa. And then amyloid, we use Congo red, crystal violet, and thioflavin T, but almost everyone uses Congo red. So in Fontana-Masson stain, you can see that the melanin stains black. Here's the epithelium, the epidermis, and you can see that the melanin of the basal keratinocytes is staining black. And here it is closer up. This would be a melanoma producing melanin, which is black. Here's alizarin red staining calcium. So this looks like some calcium deposition in some blood vessels. There's red, and in von Casa, calcium stains black. All right, so here's a blood vessel with calcium deposition in it, and it's staining the calcium black. Congo red, this would be in amyloidosis. So this is going to stain amyloid deposits, and you typically hear the birefringence. So on your light microscopy, it's this dense pink to light red. All right, and then when you polarize it, you can see birefringence. So when you move the polarization planes and change the direction of the light, in one direction it's apple green, and another one it's kind of this reddish orange. And then when you switch it, the two will switch. So as you move the polarization around, this will become the apple green, and that will become the red. And that's the apple green birefringence, and it really is this kind of apple green colors right there. So here's amyloid deposition in a blood vessel. You often see amyloid deposition in a blood vessel, and then when we polarize it, it's got this green and reddish. Here it's showing up yellowish. Oil redo, this is not many people use this. You can use it on frozen section only. It's for fat, and the reason that you can only do it on frozen section is because when we process tissue, we put it in xylene, and it dissolves out all the fat. So if you want to see fat, you have to do it on frozen tissue, and you use what's called an oil redo, and it turns it red. Okay, mast cells. What do we use for mast cells? We can use a von Letter stain, or a Giemsa stain, or toluidine blue. So here's von Letter, where the mast cells are the granules stain red. In a toluidine blue, they kind of stain this bluish purple. And on Giemsa stain, it's a purplish blue, mainly purple. And you see here the mast cells. Stains for organisms, fungi, bacteria. So we can use our PAS for fungus. So here's fungus on an H&E. This is Candida. You see the spaghetti and meatballs, we call this. So the spaghetti or the pseudohyphae, and the meatballs are the yeast forms, and here it is on PAS. So you see it brings it out. A GMS stain, very common, stains the wall of fungi black. So here it is, and this is blastomycosis, the budding yeast right there. So here's the difference: PAS red, GMS black. See that? And here's just some other examples. You can use Alcium blue and PAS. You can use you could use it. So you can combine stains to give you different information. Here's GMS, and then mucicarmine can stain capsules of fungal elements right here. So that's Cryptococcus, by the way. So Cryptococcus, PAS, the capsule is PAS positive. Spirochetes and AFB. So we use for spirochetes, for special stains, we can use a Warthin-Starry, or excuse me, a Warthin-Starry or a Steiner. For acid-fast bacilli, we use the AFB stain of Kenyon's method is what a lot of people use, a Phyte stain, or an oramine rhodamine fluorescent stain. That's misspelled. There should be a U there. So here's the Warthin-Starry stain spirochetes black, and they spiral. Spirochetes spiral, remember that. So here's the H&E, you can't see them, and all of a sudden they show up there. So here's acid-fast bacilli, stained red, and you can see that here they really are bacilli, and they're acid-fast. Okay, So, but this could be atypical mycobacteria, any type of mycobacteria, actinomyces or nocardia. One thing, what's the difference, the fight method versus acid fast cell? I've seen this on the boards in the past. A fight method is just a modification where you add peanut oil and it makes it more sensitive. And that's often, sometimes Hansen's disease will not show up with a regular AFB, and you have to add peanut oil to make it a little more sensitive. It basically changes the chemistry of the cell wall and allows penetration of the stain better. Gram stain, so gram positive cocci are bluish, or gram positives are bluish and gram negatives are reddish. Just give you an example there. Immunofluorescence is a type of special staining that we can do, where basically we use immunofluorescent labeled antibodies, and we use a sandwich technique. And just so that you know the difference, direct uses the patient's tissue. So direct immunofluorescence, you're looking at antibodies on the patient tissue. Indirect, you use the patient's serum. So you're looking for antibodies in the serum, all right? You'll see those terms and you just need to know the difference. So immunoperoxidase staining is very similar to the above, but uses antibodies linked to enzymes that produce a colored reaction. Immunofluorescence uses antibodies directed against antigens that are labeled with a fluorochrome. So here's the sandwich technique. So you've got the tissue section, you've got the antigen, and then you've got an antibody. But we increase the sensitivity by using a sandwich technique where here's the antigen, we use an antibody to that antigen, and then we use an antibody to the antibody that's labeled with the fluorochrome, or it can be labeled with a H&E color dye. So those are the two different ones. So immunostains, I'm not going to talk about direct immunofluorescence in this talk. I think it's a talk that I'll be doing upcoming, but so we're going to move on to immunostains. So the different immunostains, we can look for cytokeratins, and these are just terms you're going to hear: cytokeratin 81, 83, CAM 5.2, these cytokeratin 903, cytokeratin 7 is positive in breast. That's very important. Cytokeratin 20 is positive in GI and stuff like that. So when you trying to, differentiate a metastatic versus primary lesion, you can use these, or if it's metastatic, you can, give an educated guess about where it came from using the different cytokeratin stains. Melanocyte markers, S100, MART1, HMB45, MIT-F, SOX10. Here's an example of S100, and this happens to be labeled with a red antigen detection. You can use brown too. And here's MART. There are the melanocytes of a melanoma showing up. So back to the cytokeratins, it's a useful, you'll hear pancytokeratin, and we basically do a cocktail of AE1, AE3. And this is what it looks like. So pancytokeratin is going to stain keratinocytes and carcinomas. And here's an example of extramammary patch disease. We've actually seen this case before. We stain it with PAS, it's positive, so that those cells contain mucin. We stain them with cytokeratin, they are positive. Here are the positive cells right here. And so we know that that's a carcinoma producing mucin, so that's an adenocarcinoma. And we can confirm it with CEA, carcinoembryonic antigen, and this is positive here too. So that is an example of extramammary Paget's disease. Lymphoid markers, you've got T cell markers, CD3, 4, 5, 7, 43, 45 RO, B cells, CD20, CD34 are, that can be seen in blasts, myelocyte cells, we can stain for myeloperoxidase, which is an immunostain. Macrophages are CD68 positive, and I wanted to specifically mention this one because this one might be on your board. MUM1 is a marker for the leg type diffuse large B-cell lymphoma. So here's an example of using this for lymphomas. So here we have atypical lymphocytes. Many of them are in an intravascular location. This is a very interesting case. They're enlarged with irregular nuclei. We throw on a 3 and 4. So cytokeratin 3 is positive. Or excuse me, a 3 and 4 is negative, and we also throw on a CD20, which is positive. So the 3 and 4, so CD3 and 4 T cell markers, these cells are actually negative. When we throw on the B cell, they're actually positive. Here you can see these large atypical cells. So that's an intravascular B cell lymphoma. You can also have intravascular T cell lymphoma. So you can see how we use the different markers to differentiate the two. If we're worried about a myeloid sarcoma or a myeloid leukemia, we use myeloperoxidase, and here it is staining the cells. So these are almost undifferentiated primitive cells that it's impossible to tell what they are without using immunostains. And when we throw in myeloperoxidase, they're positive. So we know those are immature myeloid cells. So that's a chloroma or a myeloid sarcoma or a myeloid leukemia. Here's for Langerhans cells, we use S100. You can see this is normal skin with the antigen presenting Langerhans cells staining. You can use CD207, which is Langerhans. They're also staining. You can see actually the morphology of them beautifully there. And CD1A is another one that we use. We use this every day in the lab. So staining Langerhans cells. So let's move on to some cases because I think we're getting towards, you know, the time limit where you all absorb information. But here we have a neoplasm composed of a lot of enlarged cells here in the dermis, and some of them seem to be epidermotropic, so they're going into the epidermis. When we go down on higher power, look at these beautiful cells. They're super enlarged, so there's a normal lymphocyte. Always look for normal so that you can give yourself a reference. So you can see that that's like, you know, 15 to 20 times the size of a normal lymphocyte. And here it has this super irregular nucleus in almost kidney bean shapes. Doesn't that look like a kidney bean right there? So immediately on the morphology, and from those keywords I just said, you're thinking Langerhans cells. So, but those could be macrophages, those could be Reed-Sternberg cells, they could be melanocytes. That could be a melanoma. But using our immunostains, we throw on CD1A and they are positive. So this is Langerhans cell histiocytosis. And here's the epidermotropism that's showing up much better now. So here's the dermis, here's the dermoepidermal junction, here are the keratinocytes of the epidermis, and then you have these atypical Langerhans cells, both clusters in the dermis and epidermotropic. So that's Langerhans cell histiocytosis. That's going to be on your boards. S1, this tumor is also positive for S100, so don't fall down the melanoma line here. If they show you that, these would be SOX10 negative, MART1 negative, HMB45 negative, MIT-F negative, but they're S100 positive. Here's another case. So here we have a rare eosinophil and these somewhat enlarged and non-specific cells that we're not sure what these are. Are these lymphocytes? Are these macrophages? You know, some of them have a hint of a little bit of a granular gray cytoplasm. So we do need to be thinking mast cells here. So these are enlarged and they don't look like the normal fried egg mast cells. So if these were mast cells, these are slightly atypical. Meaning they're not of usual morphology, but we're going to need to throw on our immunostains to see what these are. So we could throw on CD68 for macrophages. Might want to make sure they're not melanocytes. So we could throw on an S100 and a MART. Might want to throw on a T cell marker and a B cell marker, so CD3 and CD20. And then we would also throw on a mast cell marker, CD117 is what we're going to use for immunostains. But here they are closer up, and you can appreciate the gray granular cytoplasm right there. And when we throw in our CD117, you can see that they're all positive for that. So these are mast cells. And, you know, this is mast cell disease, which requires clinical correlation. If this were a solitary lesion, it could be a mastocytoma, although usually it's a little more nodular than that. You know, if it's a more widespread process, it could be urticaria pigmentosa and even mast cell leukemia. So they can have blood involvement with secondary skin involvement, and that requires clinical correlation. But anyways, we know this is mast cell disease. Okay, here's another case. Here we have the dermis with all sorts of these enlarged cells right here. It's tough to say what they are. So just to orient yourself, here's the epidermis, papillary dermis, and then these large cells down in here. When we go down, we can see that they're very atypical. And we don't know if these are, again, these could be anything from histiocytes to mast cells to lymphocytes to Langerhans cells, you know, to a melanoma. So we really got to figure out what this is, or even a poorly differentiated carcinoma. So we will throw on our immunostains, and I'm going to cut to the chase here. CD3, which is a T marker, is negative. These, you can see the enlarged cells are actually negative, but these are normal, just a small population of T cells. But CD20, we throw it on and they are all positive. So this is a B cell lymphoma. And then we throw on MUM1, because remember I told you, we would throw on some other ones, but we use immunostains to do different types. And I wanted to give you a board question. And MUM1, this one is MUM1 positive. So this is a leg type B cell, diffuse large B cell lymphoma. And these can be very aggressive, and they don't necessarily have to be on the leg. They were originally described in the legs. They were seen in a higher frequency on the leg, and they pursue an aggressive course when they're MUM1 positive. So that's just a marker that we would use for it. Doesn't tell us it's a B cell. In fact, some T cells can be MUM1 positive, but it does tell us that if it is a B cell lymphoma, this has a poor prognosis. So not only do we use immunostains for diagnosis, we can use them for prognosis. Let's move on to another case. We want to get some board questions here. Okay, so we have a big, large, another blue cell tumor. You know, we're trying to figure out what all these are, because we just have these nondescript large cells here, but this has salt and pepper chromatin in them. See this right here? I'm using some keywords here. So we would throw on, you know, B cell, T cell markers, but we could save some money and make a guess. And this very well could be a neuroendocrine differentiation given our salt and pepper chromatin. So we throw on synaptophysin, and lo and behold, it is positive. Synaptophysin is a neuroendocrine marker. Chromogranin is positive. What else is going to be positive? Neuroendocrine carcinomas. So they show neuroendocrine differentiation and they show carcinoma differentiation. So we can predict they have to have a cytokeratin in them, right? And here's cytokeratin 20, which is classic. And what's really cool about this is that it has this perinuclear accentuation. So see the perinuclear dots? Those are keratin whorls right there to the side of the nucleus that are positive. And this is very characteristic of a Merkel cell carcinoma or neuroendocrine carcinoma. Okay, yet another nondescript cells. You know, so let's figure out what these are. Are these melanocytes or whatnot? I mean, but this does happen to be this is actually a nevus. But I wanted to introduce you to the concept of doing a dual stain. So we can throw on 2 immunostains at the same time. All right, so we could throw in a MART1 for melanocytes, and we can throw in a Ki67 for proliferation. So what that does is we literally run it twice, once with a red detection and once with a brown detection. So with the red detection is the MART1, so it's highlighting melanocytes, and the brown detection highlights cells. Ki67 highlights cells in mitosis. So we can see that there are a few melanocytes here in mitosis. So this did end up still being a nevus, but it did have an increased proliferation rate. So it was a little worrisome, and we did some other markers, but just to show you the concept of a dual stain. And then again, we can use it to detect genetic abnormalities. Also, we can use immunostains. So the classic for this is immunostains to screen for Muratori. So we use antibodies against DNA mismatch repair enzymes. So patients with Muratori have a deficiency of DNA mismatch repair enzymes. So they don't repair their DNA when it gets, when there are mutations in their DNA like all of us do. They can't repair them correctly, and thus they get tumors. All right, so that's it. And so that we can use different DNA mismatch repair enzymes, and we use antibodies to MSH2, MSH6, MLH1, and PMS2. So those are different antibodies to different DNA mismatch repair enzymes. So we're faced with a sebaceous neoplasm in an older patient, let's say on the face. And, you know, this one would end up being called a sebaceous adenoma, but you can see sebaceous adenomas in patients with Muratori. So the question is, do you want to screen for it or not? And we won't get into the algorithms for that, but I will show you how we would do this. So it was decided to screen for Muratori. So we did the DNA mismatch repair enzymes. And what it is when you, in this case, it's a loss of the staining is positive because they have the enzymes don't match up to the antibodies. And so you can see that that's an abnormal enzyme in this patient. So keratinocytes normally have DNA mismatch repair enzymes intact. So you can see the keratinocytes are positive. but the actual sebaceous neoplasm is negative. So negative is positive in this case. So this was a positive screen. And here you can see that the nuclei of the sebocytes are negative, so they don't have it, and the keratinocytes do. So that's an absence of the enzyme or an abnormal enzyme that's not picking up the antibody. And this would be a typical report. So this would be an atypical sebaceous neoplasm. It's abnormal deficient staining pattern for mismatched repair proteins. And this one happened to be for these two, which are often paired together, and in normal intact staining. So this patient could have Muratori or Lynch syndrome. Those are different subsets of the same process going on. But I just wanted to introduce you to that concept. And I think many of you are familiar with it, but we do it daily in the lab. Finally, we have another case here. We have these nondescript cells right in here, but they seem to be mixed. We have some enlarged activated cells. We have some neutrophils and whatnot. And this doesn't really look neoplastic. It looks more reactive, but we have epidermotropic lymphocytes and so the question, and macrophages here. So the question is could this be infectious? And could these macrophages be harboring organisms? So we can throw in our PAS stains. We can throw it for fungi. We can throw in our acid-fast for acid-fast bacilli. And we can polarize it for foreign material. And then the other thing is we can use specialized immunostains. So because we have a few plasma cells here, actually this is probably a plasma cell. Oh, here's a good plasma cell right here. Here's the perinuclear Hoff. With epidermotropic stuff going on and a little bit of pallor up here and some neutrophils, you got to be thinking about syphilis here. And so what can we do? Well, let's throw on our PS, make sure it's not fungus. That's negative. Our phyte stain is negative, and we'll throw on an immunostain for Treponema pallidum after we do a gram, and it is positive. Here are the spirochetes of Treponema pallidum. So here is an example of a Treponema pallidum immunostain making the diagnosis of syphilis. So that is absolutely diagnostic. One last case here, we have blood vessels. So we're kind of getting into using the immunostains for infections. We have an increase in blood vessels in an older patient or an HIV positive patient. So at first blush, it kind of looks like a hemangioma or a low-grade angiosarcoma, but what we can do is we throw on HHV8, which is known to be associated with Kaposi sarcoma. And here the staining is positive. See these nuclei staining right here? Not all stains are like in your face positive. They can be very subtle and they have different characteristics to them, but this is characteristically what a positive HHV8 looks like. So you can see the endothelial cells are positive. So that is Kaposi sarcoma or Kaposi sarcoma, depending on how you do that. So anyways, that's basically the end of the presentation. I hope you got a better feeling for immunostains and special stains and how we can use them, and the breadth from looking at specific cells to looking at different types of deposits or normal anatomic structures, and then also special stains for organisms, both classic special stains and immunostains. If you have any questions, please feel free to contact me through the education emailing, and I'd be happy to answer any questions. And I look forward to giving you lectures in the future. Take care and have a wonderful evening.
Well, thanks so much, Trey. Great talk. Hope everybody found that useful. As you can see, there are a wide variety of applications for both the histochemical and immunohistochemical stains. And probably, sometimes your IHC stains are very targeted. As in the case of, say, Kaposi sarcoma. A lot of times, though, if you're looking at an infiltrate and you're not too sure what the histogenesis is, you're going to order your immunos in a panel. And you don't want to just throw the kitchen sink at it, because the immunostains are usually about $100 per pop. So it's a good idea to have a differential and then target your immunohistochemical stains and order them in a panel. So generally on a test or in real life, we'll talk about ordering a panel of immunohistochemical stains. Anyway, thank you for your attention. And again, if you have any questions, please feel free to reach out. Have a great evening. Thank you.